Bismillah ar-Rahman ar-Rahim. Today I will be talking about Parkinson's disease insights and limitations. This is the lecture that I recently did for my neurosurgical colleagues, and it is something to understand the scope of treatment, especially when it comes to Parkinson's disease. So Parkinson's disease is the second most prevalent neurodegenerative condition after dementia. Almost 1% of the people more than 60 years of age have Parkinson's disease or develop Parkinson's disease. And it is a complex, heterogeneous, and progressive neurodegenerative condition. Complex because it can present in many different ways, and it is hard to treat based on symptomatology. Those symptoms could be heterogeneous, and with passage of time, it worsens. So there is no going back. From a neurologist perspective, what we do in clinic is getting a detailed history of what patient has. The most common symptoms a patient notice with Parkinson's disease is tremor. The best way to remember the common symptoms is TRAP, T for tremors, R for rigidity, A for akinesia or dyskinesia, and P is for postural instability. The tremors are seen in almost 90% of patients with Parkinson's disease. It could be restoring tremor, but sometimes patients are seen to have mixed tremors, including postural and action component as well. But what is more important to recognize is the non-motor symptoms of Parkinson's disease, which could be psychiatric, including depression, somnolence, anxiety. There could be cognitive side effects, dementia, which could be part of a special variant of Parkinson's disease. There could be autonomic dysfunction resulting in bladder symptoms or constipation. There could be sleep problems, including hypersomnolence, insomnia, but more importantly, REM sleep behavioral disorder. There could be sensory abnormality like change of taste, different in smell, or loss of smell. The examination is based on the history, but it should include all the components of Parkinson's disease. So not only the routine neurology screening exam, but also we need to do dedicated exam for Parkinson's disease patients, especially when we are suspecting this patient is having Parkinson's disease or any atypical variant of it. The clinical diagnosis is based on history and examination. There is no definitive test to prove Parkinson's disease. We can sometimes do imaging, including single photon emission computed tomography, to differentiate Parkinsonian tremors from essential tremor, which is another neurodegenerative condition. But other than that, the diagnosis is mainly based on history and examination. And I cannot say more about the importance of history in these cases. Parkinson's disease has many subvariants or atypical forms. The common ones are progressive supranuclear palsy. These patients notice some gaze abnormality, especially vertical gaze abnormality, and tend to fall. Cortical basal degeneration is another variant where there could be cortical signs. Diffuse body Lewy body dementia is one subtype where dementia presents earlier, but it's a combination with Parkinsonian features. Multisystem atrophy is also further subdivided into MSAP, which is P for Parkinson, and MSAC for cerebellar. And again, as the name depicts, it can present with predominance of one or the other symptom or the system involved. Secondary Parkinson's disease could be medication induced, like it can be seen with certain toxins as well. Most commonly, antipsychotic medications and other prokinetic medicines can give Parkinsonian features. Vascular Parkinsonism is one which is seen in patients with repeated strokes and with extensive small vessel ischemic changes. Repeated head injury, especially as seen in boxers, can give secondary Parkinson's disease as well, or post-encephalitis after brain damage. There could be psychosomatic slowing, which can present like Parkinson's disease, but it is usually secondary to hypothyroidism or some other condition. Toxin-induced Parkinsonism could be because of methylphenyl tetrahydropyridine, which is a known toxin to cause Parkinson's disease. There could be genetic Parkinson's disease, especially when there is a positive family history. Brain tumor can sometimes mimic Parkinson's disease as well, especially with slowing. Movement Disorder Society has developed a score called Unified Parkinson's Disease Rating Scale, which is done before and after surgery in these patients to see the extent of the disease. Is it mild, is it moderate, or severe? The four main domains checked in this scale are cognition and mood, activities of daily living, motor examination, and motor complications, which could be because of the medication. The medical treatment includes multiple drugs, but levodopa is the gold treatment for Parkinson's disease. It is with combination of carbidopa, which is dopa decarboxylase inhibitor, and inhibits the conversion of levodopa peripherally, which let it have longer sustained duration of action in the brain. Levodopa do come in many different formulations. It can be used as inhalation. It could be slow release or extended release formulation or immediate release formulation. It can be used as intestinal gel through PEG-J, especially in advanced Parkinson's disease. Dopamine agonists have longer duration of action. It can be used in younger Parkinsonian patients, as the younger Parkinsonian patients tend to have more issues with aggression and obsessive compulsive behavior. The patients with late onset Parkinson's disease tend to have more cognitive issues. The patients with early onset Parkinson's disease tend to have more motor fluctuations. Catechol or methyltransferase inhibitors are medications which also have duration of action prolonging property. So if it is used with levodopa, carbidopa, it reduces motor fluctuation. Monoamine oxidase B inhibitor can also be used for motor fluctuations. Amantadine can be used for antidyskinetic properties. Trihexyphenidyl and benzatropine are medications which are primarily used for tremor in patients with Parkinson's disease. There are many surgical options available and many targets which can be achieved. Deep brain stimulation is a device which provides different frequency, duration, and pulse width of electrical stimuli in particular targeted brain areas, which could be subthalamic nucleus, globus pallidus interna, ventral intermedius nucleus of thalamus, and substantia nigra reticulata. The DBS is primarily managed by the neurophysicians, who actually plays with the frequency, duration, and pulse width of the electrical stimulus and try to achieve better control of the disease. But what we need to understand is that medical therapy and DBS can help in some symptoms, but in not all the symptoms of Parkinson's disease. So it is very important to understand who will be the patients who are gonna respond better to DBS treatment, because it costs close to 4 million rupees. So these patients should be properly selected. Who should not get DBS for Parkinson's disease includes one with psychiatric manifestation of Parkinson's disease, like dementia, or those who are having atypical Parkinson's disease. There are other treatments which are cheaper options for Parkinson's disease patients, and one is focused ultrasound ablation therapy. It was initially used for the tremors in Parkinson's disease, but in 2021, FDA has also approved it for dyskinesia and rigidity in Parkinsonian patients. These therapies, including stereotactic surgery, are permanent damage, so there is no reverse in case these patients have these treatments. In case of DBS, it's relatively safe, but it is expensive. So in patients with living in developing countries, surgeons should make a choice and help patients achieve the goals of better quality of life. There are other modes of treatment in these patients besides medications and surgery, and most important is physiotherapy. So whatever phase of disease you are in, early, late stage, or after DBS, you should continue to do physiotherapy, which is dedicated towards Parkinsonian patients. These patients need to develop what we call patient diaries or Parkinsonian diary to see how their symptoms fluctuate, so their medication can be adjusted accordingly, and we can try to help them in terms of medication-related side effects. Patients who are having advanced Parkinson's disease and they are not candidate for surgery, they can have PEG-J tube for intestinal gel to relieve their symptoms, but these are usually advanced patients. This is my clinic data. So I have seen close to 177 movement disorder patients. Out of those, there were 70 Parkinsonian patients. The typical Parkinson's disease patients were 40, and atypical patients who were diagnosed on the initial visit was 23. The secondary Parkinson's disease was seen in 3 patients, and the most common reason was medication, especially antipsychotics. And I have 1 patient with family history of Parkinson's disease and genetic etiology. There are certain limitations to care of these patients in developing countries, especially lack of early recognition of non-motor symptoms. Almost 25% of the Parkinsonian patients are misdiagnosed early in the disease, which delays the diagnosis and end up in polypharmacy, which actually result in loss of trust of these patients on the physician. Also, in developing countries, there is a poor referral system, so it takes a long time for a patient to get to the right physician to be seen and to be selected, even if they are candidate for surgery. There is a lack of multidisciplinary approach. That's why very few people or patients come to the point where they can get high-end quality care. There's no understanding about the role of physiotherapy, which is needed in these patients at every stage of their disease. So in summary, Parkinson's disease is progressive heterogeneous disease, as I mentioned before. There are multiple medications and surgical target options available, but what we need to understand as physicians and also need to communicate to our patients is about quality of life issues and to help them make better choices, even if in terms of medication, PEG-J tube insertion, or surgical planning. What we don't know what's going on, then we should refer these patients to the respective physicians or to another physician to have a second look on these patients. Multidisciplinary approach is key to patient satisfaction and quality of care. We should also develop interest group. So there is a dedicated group of interested physicians and surgeons who like to take care for these patients and provide quality care. And with the passage of time, we will be able to develop a better support system for these patients. In the last slide, what I can say is only together working with our patients, both as physicians and surgeons, we can provide this ladder of care and get them to the point of better quality care. Thank you so much.